Okay, I'm gonna record. So has anybody had a chance to look at the study guides that I sent out that we're going to go over today to kind of look at chapters 23 and 24? Nobody wants to talk. That's okay. All right, so we're just gonna dive right into it.
No, you're fine. It's muted. Oh,
Oh
maybe
yeah,
it's not muted. Sorry, Rebecca.
no, that's okay. I was like,
Sorry.
sometimes people don't want to talk. It's all right. So Bianca, were you able to do any of the study guide?
No, I haven't looked at them. I'm in Portland.
Oh, fun. What's in
Yeah.
Portland?
My husband's building a new Ace Hardware, so I'm here helping sorting stuff.
Oh, that's what I saw
Yeah.
when you came on the screen. You were wearing an Ace Hardware
I
shirt.
know. I'm repping
Very
the
cool.
brand.
Hey, I love
Yeah.
Ace Hardware. They're always so helpful there.
Yeah. So yeah, we're in Portland for the weekend.
Nice.
Yeah.
Okay, well, I know these chapters can be kind of dense. So one of the things I wanted to really encourage you guys is to kind of look at the general pieces. Um, Let me pull up because I was going to record a lecture for you guys, and it's just so dense. I was like, I'd rather just kind of where we talk to you guys and kind of go over some specifics or more specifics. All right, sorry, I'm pulling up my PowerPoint. I didn't have it up. Do, 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 do. Okay, here's my Zoom. I'm going to share my screen with you guys and show you, and I'm going to show you kind of what I'm going to publish this on Canvas so you guys can all see. So here is the PowerPoint for chapter 23 that I started making. So here, when we're looking at different types of valvular issues, so specifically, I think this is where we're going, looking at like stenosis, right? And who wants to say, like, what is stenosis? Can anybody tell me what that is?
This isn't like decrease oxygen around somewhere. Is that
Good guess, but no, stenosis is more like, I like to think of like a hardening, where
hardening?
normally the valves will open and close. So like, and if you see in the picture here, there's both the mitral valve that's right here or the aortic valve. Normally they'll open up, let blood flow, and then come back. A stenosis is when they get hardened kind of, and they don't open and close nearly as easily as they should. And because of that, blood can't flow like it normally would. So in the book, it goes kind of a lot into, or just not a lot, but it goes more in depth into mitral stenosis versus aortic stenosis. And so instead of having both of these in different slides, I went ahead and put them in side by sides because when you look at them, it really, the ultimate thing that I want you to know is that it decreases the cardiac output because blood flow it just can't flow as easily through those hardened, stenosed um, valves. And so the cardiac output decreases. And so when we look at that, oh, sorry. I need to get rid of that. So etiology, like what causes it? So you can see in both of these, there's a lot of similarities, right? Rheumatic fever can be a cause for those ones. Could be congenital defects. There could be some calcium deposits or calcifications. Signs and symptoms, a lot of times there's none. So I'm not going to go through all of these, but when you're looking at these, I really encourage you guys, especially with a lot of these cardiac disorders where you're like, oh my gosh, like how do I memorize all of these things? There's so many of these conditions where it doesn't matter if it's mitral stenosis or aortic stenosis, excuse me. For an example, you don't have to memorize all of these. I wouldn't memorize. I would know some generalities and then also know there's some really big similarities between mitral and aortic. So if you can remember, okay, they're both maybe not have any signs and symptoms. They're both probably going to have some murmurs, knowing those general things that's going to keep you from feeling like you have to memorize every single thing. Does that make sense? Any questions?
So is there some like major differences we should know about the two things?
No, I don't think so. And this is more, I was just using this as an example because so much in the cardiac system, when we'll talk about it a little bit later, there's so much, there's like general things and then like an issue, and then there's all these things that cause the issue or it could be from different, gosh, sorry, I need to drink more of my coffee. The words aren't coming right. Um, talking about stenosis here, we might be talking about regurgitation in a little bit, right? Those things, I mean, I don't care so much if you know specifically which valve is causing it, other than just like, does it make sense? Right? So based on the pathophysiology of the heart, if we're going to go back here, if you have regurgitation, and so who can tell me like what is regurgitation? Anybody?
I'm assuming you're talking about heart and not like general regurgitation, right?
Well, right, but even if we're talking about the heart or general, it's going to be kind of similar, right? Like something is probably backflowing or going back where it shouldn't,
Oh, so like
right?
if there's a valve issue and it's not strong and it's not closing like it should, that means you have backflow. Is that regurgitation?
Yeah, exactly. So that's a great way of describing it, Eric. There's backflow that's happening. And so when they talk about different valves having regurgitation or backflow, that's something that's really important to know, like, hey, where is that valve and what's maybe happening? So here, like if there's aortic regurgitation, that means that it's backflowing back into this chamber of the heart, which chamber of the heart is this one here?
Left ventricle.
Yeah, I was gonna say it looks like a V because it's at the bottom. So that's the ventricle. Yeah, and it's the left ventricle. And so the left ventricle, if you guys remember from anatomy and physiology, or I'm pretty sure Abby goes over it a lot when you guys do cardiovascular assessment. That's the blood there, that's the chamber that pumps everything out into the heart, right? So if you have issues with that regurgitation coming back, it's not going to pump as much blood out into your body, right? You're going to have issues. Um, you might have hypertrophy, right? This is going to be getting bigger. It's going to be filling with more and more blood. It's going to be trying to forcefully push more and more to get more of that blood out. So it's kind of more of if you understand the pieces of the heart where they are, and if something's dysfunctioning, that kind of will tell you what's happening. So I think that might answer the question. I really want you guys to know more generalities with this information. All right, so I was just showing you kind of this piece as a example. I think if you're studying, I think it's a great idea to go through and like make lists like this. If there's different disorders, but they come from different areas, like there's stenosis that's aortic versus mitral, go through and make different lists to say, hey, how are they similar? Maybe what's one or two things that are different. All right, I'm going to stop this share and I'm going to go ahead and start sharing. Oh, what is that? Oh, sorry. I'm going to start sharing the study guide. And if you haven't done the study guide, not a big deal. We're going to go through it together. We'll see how much we can cover in the time. All right, so let's start with chapter 23. And I want to totally recognize that this material is kind of dense. There's a lot to it. And that's why I kind of want to go through a little bit of just, hey, what are general things and what do we need to know about it? Let's go back to sharing the screen. Do, 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 do. Okay. All right. Can everybody see the workbook that's up here now?
Yeah.
Hopefully. Okay. How do you guys feel about vocabulary? just in general, like when you're reading through the book, or if you're looking in lectures and things, do you feel like you're understanding a lot of the words?
Some stuff,
Stop.
and then some stuff I have to Google just to understand it. Yeah.
Google all day.
Google all day.
Yeah.
And Google is super helpful. I really do like that the book, for the most part, especially with word building, which is, I keep saying, like, this is the first time we've taught out of this book, but we really did look through different publishers and different books and try to find ones that really, first of all, focused in on what's important for you guys to know, but then also made it easier to learn. Like, one of the things I really liked with Davis is that they do this word building, and they kind of, because if you can learn the building blocks of a lot of these terms, even if you don't know some of the other words, usually you can kind of figure out what they mean. So let's just kind of go through and look through. So annulus, or ring, and plasty. Anybody know what that word might be? Get my little book out here, make sure I can cross-reference this too. Chapter are we on, 34? There we go. All right, so that one is annuloplasty. And that, I believe, is when you're building another ring or valve, something like that. You know what? I don't really care if you guys know some of these. So let's skip over. I'm going to do the ones I think are more important for you. So number 4, Eric, you already kind of had that one. So means again, and gurgitare, which is to flood. What would that word be?
Regurgitate.
Yeah, regurgitate. Right. So that's,
So,
oh, go ahead.
so then is number 1 angioplasty?
Yes, yes.
Oh, okay. I was confused because it's a little confusing.
Yeah, that word is a little bit more confusing. I'm not so worried about that one. I want you to know some of these other words like stenos, right? Like when we look at the heart, like the word that we're filling in, really it's stenosis, right? That's the process of them having a narrowing of the heart. But if you know that stenos means narrow, that's going to help you understand what that means.
Wait, I think angioplasty is different than annuloplasty.
Oh, did you say angioplasty?
Yeah.
I thought what?
Oh,
Yeah.
thank you for, no G, just annuloplasty.
Okay.
Gotcha. Um, I don't know where my controls are at, but I don't think there's anybody waiting in the meeting room. If anybody, can you guys hear when somebody's waiting?
I don't think
I
so.
don't know.
Not so much? Okay. I just want to make sure if somebody's waiting. So, well, hopefully we'll be okay. Um, Give me 1 second. Oh, I'm in the totally wrong chapter. No wonder I couldn't find the word I was looking for. Give me one moment, guys. What about this pericardia kentesis? What word is that building?
The pericardiocentesis.
Yes, yeah. And so if we
Ooh.
understand the wording blocks, that's so good. We can understand what it is. So pericardia or pericardial, that's the area, kind of that little area around the heart. And if you have a pericardial effusion, which we learned about effusions with the lungs last week, what is a pericardial effusion?
maybe water between the lung and then something.
Yeah, so not around the lungs, but an effusion is a buildup of fluids. So if a fluid is building up in the pericardium, it's around the heart. And so when you have a pericardial effusion, you have your heart and this little sac that's around it. But when you have fluid build up in that sac, it's putting pressure on the heart. And it can get to a point where the heart can't beat like it needs to because it has so much pressure from those fluids. And so a pericardial synthesis, that's the treatment for it. And so what is that doing, that pericardiocentesis, cardial?
Remove the fluid, I guess.
Exactly. If you ever get a chance to see them, they're crazy. They will use an ultrasound to guide, and they stick a needle into the heart, not into the valves, but or not valves, excuse me, not into the chambers of the heart, but right into that sac that surrounds the heart to pull the fluid off, to relieve that pressure. So that's why I think it's really important if you can look through these words and understand like some of these, the building blocks. That's going to help you understand what the process even is. Like thromb, phleb, vein, itis. So thromb is a clot, phleb in the vein, and itis is inflammation. So we know that a thrombus, that's a blood clot. But the itis, what is that? That's when the blood vessels around where that clot is get really inflamed. All right, I'm going to move on. Unless does anybody want us to break down another one of these words? No? Okay. I really like these little pieces, these find the errors, because they kind of help us to kind of say, do we know what we're talking about, or do we need to go back and correct? So I'm going to read through this. How about I just want to read through the first paragraph and then tell me where you think there's an error. So there are, how about, let me tell you, there's 1, 2, 3, 4, 5. There's 5 errors in this first paragraph. And let's see if we can find them. So during ventricular diastole, when pressure in the left ventricle rise, the leaflets of the mitral valve normally remain open. In mitral prolapse, however, the leaflets bulge backward into the left ventricle during systole. Often, there's a functional problem seen with MVP. However, if the leaflets do not fit together, mitral stenosis can occur with varying degrees of severity. All right, anybody see an error or something we need to change right off the bat? What about this first sentence? During ventricular diastole, when pressures in the left ventricle rise. So remember when we're taking blood pressures, right? Go back to foundations, beginning of last term. You're measuring systole over diastole, right?
I think diastolic is relaxing, right? The
Yes.
pressure moving to decrease, not increase.
Exactly. And so for this sentence, these don't match, right? The pressures are increasing, but not in diastole, but it's in systole, right? So here we would want to change this to systole or systole. I guess some people say it differently. I think it's fine either way. So when the pressures are highest in the left ventricle, that's when that's during systole. So great job, Hannah. All right, let's keep going. The leaflets on the mitral valve normally remain open.
They close.
Yeah, they're normally closed during ventricle systole. In mitral valve prolapse, however, so this is prolapse, and did we talk about prolapse a little bit earlier? I'm not sure. We talked about stenosis, and that's where it gets kind of hard and doesn't move. Prolapse is where the valve normally will open and close, and this is where they'll open and then they'll like suck down in and they become ineffective, right? They're going to open and close, but everything kind of stays open a lot more. All right, I probably just gave you the answer to the next one. Let's look. However, the leaflets bulge backward into the left ventricle during systole.
You just change it to diastole? No?
No, not diet, because they do. So they will remain closed, but then they bulge back during systole. But let's look about where, like, remember the mitral valve? Are they bulging back into the left ventricle or into the left atrium?
Atrium.
Oh, yeah,
And
atrium.
they're gonna go into the left atrium.
Because if they're prolapsing into the atrium, and that's the abnormality.
Exactly. They're going to the wrong place, essentially. Often there are functional problems seen with MVP. This is kind of a tricky one. It's often there are no functional problems. So a lot of times people can have prolapse and even some regurgitation, and there's no problems. There's no symptoms. It's when it becomes more severe or if it becomes more severe. Some people might have this for years and never have a problem with it. But if the leaflets don't fit together well, mitral stenosis can occur with varying degrees of severity. All right, so it's not that stenosis is going to occur here.
Regurgitation.
Yes, exactly. That's where we might see a problem. If there is, oh, what's the word when it flaps back and forth? Why am I'm losing it? Prolapse. So sorry. The prolapse isn't necessarily the problem. It's what happens with prolapse is that and that's where you're going to have regurgitation, right? The blood flow is not, it's not going to be normal. If it's prolapsed in, it's open and it's allowing for blood to regurgitate back from where it came from. In this situation with the mitral valve, it's going to be back into the left atrium. So then it's like, okay, are they having a problem from that? All right, let's go on down to the next one. Okay, the next paragraph, there's one, two. Oh, there's only 3 problems in this one. So MVP tends to be hereditary with the cause known. Infections that damage the mitral valve may be a contributing factor. It's the most common form of valvular heart disease. Most patients with MVP have symptoms. Symptoms that may occur include chest pain, arrhythmia, palpitations, dizziness, and syncope. No treatment is needed when symptoms are present. Stimulants and caffeine should be avoided to prevent symptoms. All right, this is a little trickier because there's only 3 problems. Anybody want to take a guess at which one is one?
No symptoms?
Mm-hmm. Yes, so most people with MVP have no symptoms. So that's one, there's 2 more.
I cheated because we kind of talked about that in the first paragraph.
I don't think it's cheating. I think you're using context clues and you're referring back to what we talked about. Not cheating at all.
I thought that it tends to be hereditary, but there's no known cause.
Yes, exactly.
It
With
just
the
like
cause,
happens.
yep, the cause is unknown. Great job, Erna. All right, the last one. What about treatments?
You do need treatment with symptoms.
Right, right. So here, what they're suggesting is no treatment is needed unless symptoms are present, right? Because we're not going to treat something that they're not having an effect of, or unless they're having an effect. All right, nice job. You guys give yourselves a high 5. You identified all of those. All right, let's get into a little bit of true false. And I just need to blow my nose. Hold on. Okay, sorry about that. All right, stenosis is a widening of the opening of the heart valve. Is that true or false?
false
Yeah.
False.
Yeah. And why is it false? What would make this sentence true?
because of
Yeah.
the hardening of the valve, like of the vessels.
It's hardening or like a narrowing, right? They're not as
Mhm.
flexible. And so they make that narrowing there. Yeah. Number 2, stenosis inhibits the forward flow of blood.
True.
Mm-hmm.
True.
Yeah, true. Because it makes that narrow, it doesn't let blood flow as easily. So regurgitation, oh, sorry, moving on to number 3. Regurgitation or insufficiency is failure of the valve to close completely.
True, right?
True.
It's
True.
true. Yeah, good job, Hannah. Yeah. Regurgitation, it doesn't close all the way. And then down here, regurgitation inhibits a backflow of blood. Is that true or false?
False.
False.
False, right. And so what would
False.
make this statement true?
Just make it backflow, right?
Exactly.
Causes. Yeah.
Yeah, regurgitation allows or causes a backflow of blood. Rheumatic heart disease and congenital defects are causes of valvular disease.
True.
Yes, true. I don't really care a lot about rheumatic heart disease. There's a couple things you guys should know that it usually happens with children. They get kind of this overall rash. It usually follows a staph or a strep staph. Oh Lord. Now I'm going to have to look it up because I don't remember. I believe it's strep infection. Boop-a-doo. Hold
Yeah,
on.
it's strep.
Strep. Okay. Thank you. Yeah, strep infection. And so after that, and normally we can get a strep infection, and we're not, we recover. Occasionally, that strep infection essentially can go to the heart, and people can have rheumatic fever. And, you might see things, a lot of times they're not super ill with it, but they can have fevers, these like little like rashes everywhere. Sometimes they can have this like spasmodic movements. Sometimes you don't even have symptoms for years. But if they're diagnosed with it, we know they're a higher risk of having these valvular diseases. All right, number 6, moving on. The primary valves affected by the disease are the tricuspid and pulmonic valves. Yeah,
False.
which valves have we been talking about?
Aortic
Oh,
and
mitral.
pulmonic.
Yeah, exactly. Aortic and mitral. Good job. Number 7, a commissutorotomy narrows the valve opening. I don't think I said that right.
Can I ask a question real quick?
Yeah.
So that means a way to remember that, if I understood that, with valve issues, valve issues are usually the left side of the heart valves rather than the right.
Yes. Yeah, that's a
Okay.
great way of remembering it. Yeah. When you have valves that are affected, especially with like rheumatic fever or with regurgitation, stenosis, it's usually the left side of the heart. All right, I don't know how to say this word very well. Commissutorotomy. Does it narrow the valves opening? It's false. It actually enlarges it. So when you have like a valve that is stenosed, or it won't really shoot. Sorry, I just about knocked over my lamp. When you have, usually it's with stenosis, and you can't, like, the valve isn't moving and it's blocked, like there's no blood flow that's able to go through. Sometimes they will, remove part of that to allow blood to flow more easily. All right, symptoms of valvular disease often occur early, and they mean early in the disease process or early when it begins to happen.
False.
Yeah, false. When do they occur?
Later.
Yeah, it's usually later when it actually causes issues. All right, in severe valvular disease, heart failure occurs.
True.
True.
True, yeah. And I want to focus on this just for a minute, because if we think about the heart being a pump, right? It's a really effective pump. And we have these 4 chambers. We have the 2 atrium and the 2 ventricle, and they each kind of pump into the next chamber, or the right ventricle pumps into the lungs, right, that then come into the left atrium. They all kind of have this flow. These valves are what keep things where they should be, you know, during systole or during diastole. Diastole? Why am I saying that weird today? I don't know. Ever wake up and just say words weird? When the heart's relaxed, those valves are going to keep the blood in the chambers or going to keep it in the lungs where they're getting oxygenated. But during systole, that's when the pressure increases. They're working on pumping, or their valves are opening and allowing blood to go through. That's how it's supposed to work. If there's some issue with these valves, then that pump is not nearly as effective as it should, because blood is either, if it's stenosis, it's getting stuck in the valve where it's at. If there's regurgitation, it's maybe the blood's going into the next chamber, but then it's kind of backflowing down in. And so there's issues where the blood's not going where it should, or not going as effectively as it should. Because of that, it causes heart failure. So a lot of these symptoms that people are going to have over time are usually symptoms of heart failure. We'll talk more about that. I think, is it next week we do heart failure? I have to look, but we'll talk more about heart failure in a couple weeks. All right, so in acute valvular disorders, moving on, symptoms of shock can occur.
True.
True, yeah. And you guys are going to talk more about different types of shock next term, but there can be like a cardiogenic shock, and essentially, you know, you're not getting enough oxygen or your heart's not pumping enough as it should. Annuloplasty surgically repairs the valve.
True.
True, correct. Valvuloplasty uses a balloon to separate the valve leaflets.
False.
That's actually true. So I think,
Oh.
let me share my screen again and show you guys. All right, are you seeing a picture of the heart?
Mhm.
Yeah, okay. So here, the aortic valve is stenosed. They get this little balloon, and they thread it through this valve, and then they blow it up to try to open up or increase. And then this is like a one-time thing, right? They don't leave the balloon there, but it hopefully will help that valve to become a little more pliant, to stretch a little more, be able to move a little bit more. Because sometimes it's stenosed, it is just like stuck. It's not, especially when it's more extreme, it's really not doing much. So this would be somebody who's having severe symptoms, right? If somebody has minor stenosis, it's not causing a lot of symptoms, they're not going to go and do a balloon valvuloplasty. But somebody who is more advanced, they're having a lot of symptoms, they're having some heart failure issues, they are going to go and try to make that valve a little more movable, kind of get it moving more. Any questions about that?
What's it called then with the replacement of the valve?
Oh, great question. Just replacement.
Oh, okay.
Which is the next slide, which is right here. So here you can kind of see, like, and this is not a great picture of it, but essentially they go in and they will replace the valve altogether, right? And so if the valve is so stenosed and they can't get it moving more with the balloon, they might need to go in and put a mechanical valve. Fun fact, when you have patients with mechanical valves, you can hear them, sometimes even across the room. Clinical in the fall, I had students at the hospital, and my student was like, "Oh yeah, they have a mechanical valve." I'm like, "Did we hear it?" And they're like, what do you mean hear it?" I'm like, "Did you listen to their heart?" So a bunch of the students, we all went in and listened to his heart, because for me, an experienced nurse, I could come in and when it was quiet, I could hear that mechanical valve opening and closing. And when you auscultate the heart sounds, you could hear it, like it sounds like this click. It's like this click, click, click. And I mean, it's not like super loud, but I mean, it's audibly, you can hear it. It's really interesting. All right, I'm gonna go back and share our workbook that we were working on. All right, compensatory mechanisms in valvular disease are cardiac dilation to handle increased blood volume and hypertrophy to increase the strength of contractions. True, yeah. So when we have valvular disease, and we talked about that heart being the pump, and the blood isn't going where it needs to go or should go, sometimes we have to, dilate. Like in the aortic regurgitation, right? Your left ventricle is going to end up dilating because it's got more blood that it has to handle. And it's going to eventually, that left ventricle is going to hypertrophy or grow even bigger. The muscle of the left ventricle is going to grow bigger because now it has more blood flow and it's really got to work harder. Just like if somebody's going to the gym and they're strength training and they're like, I really want biceps, and they work really hard at biceps over and over and over again. That's what our heart is doing because it's having to work over and over to get that blood out. And so it ends up growing bigger than it normally would.
And is that where Abby was talking to us about how when that happens, like that left ventricle, because it hypertrophies, it reduces the stroke volume and the cardiac output. And that's what
Eventually,
contributes to the heart. Yeah, and eventually right-sided heart failure.
yep, eventually it
Okay.
can. Yeah, yep, yeah. Yeah, and that's the thing that all of these things, when we talk about heart failure, and like I said, we'll get to it more in depth in a couple of weeks. When you have all of this very complex pump, which is your heart, if you have one thing that stops working, if it continues, right? If that continues and gets worse and worse and worse, eventually the whole system is going to be broken, which is going to lead to heart failure overall. So that's the piece. Like some people talk about what is left-sided heart failure, what is right-sided heart failure. I mean, ultimately, if you have one or the other, it's all going to end up to be overall heart failure because it's all part of the same system, excuse me. All right. Next, true or false? Tests to diagnose valvular disease include electrocardiogram, chest x-ray, examination, echocardiogram, and cardiac catheterization.
False.
What would be the false one?
The chest X-ray.
No, they're all
No.
true. Yeah, they're all true. And one thing,
The
because we think,
cath.
yeah, so they're all things that we would use to help diagnose. The chest x-ray is something that would really be helpful if somebody has hypertrophy. So if their valves are getting a lot bigger, or not valves, excuse me, if the ventricles are getting a lot larger to manage that flow, then you're going to see that on your x-ray. Your heart, where normally it would be maybe this large on the x-ray, it's going to be this much larger. They're going to be able to see it's larger than it should be. And then the catheterization, they might have to go in if they're not sure what's happening. They might want to go in and kind of see more specifically about where the blood flow is landing. And excuse me, I'm sorry, I need to blow my nose again. On a side note, I just want to let you guys know I am no longer the case study for our class. Now that we are into cardiac, I refuse to experience any of these things for the benefit of the class. Just PSA letting you all know. Ooh, funnier to me. All right, number 15. Patient teaching for valvular disorders includes understanding the importance of prophylactic antibiotics before all invasive procedures.
False.
Yeah, false. It's only certain invasive procedures if they have valvular disorders. All right, let's read through critical thinking and clinical judgment. So Mrs. Murphy, who's 72, has aortic stenosis and she's admitted to room 536 for an aortic valve replacement tomorrow. She reports fatigue and dyspnea with exertion. Vital signs are pressure 138/82, pulse 92, respirations 20, temperature 98.4. During ambulation in the hallway, she experiences an episode of angina that's relieved upon return to her room in a wheelchair with rest. Her surgery and recovery process is explained to her. All right. What could be the cause of Miss Murphy's aortic stenosis?
Hereditary?
Absolutely. It could be hereditary. Anything else? There's another one that's kind of big.
Well, I feel like, I mean, it's probably wrong, but like, I was thinking of the test questions, like just stable angina, because it went away,
Oh,
but I don't think it's a cause.
right, right. I think that would be more of like a symptom. But let's look at her
Blood
age.
pressure.
Oh, I love that we're thinking through her age. She's older. She's 72. As people get older, and from earlier when I was showing that PowerPoint that kind of showed the similarities and differences between some of the valvular disorders, sometimes they can have calcifications that happen. Those are more common as you age. And even if you weren't thinking about calcifications, think about our heart as that pump, right? Over time, any pump is going to give out. It's going to not be able to work as well as it should. And at 72 years, that pump's been working for a long time. So that's another big risk factor for her. All right, moving down. How does the heart compensate for aortic stenosis?
I think make a new way, maybe like new path.
I like that what you're thinking. The only thing is with the heart, there's not really a new path, right? There's kind of only one direction and one place it can go. So if there's only one place it can go, so remember with the aortic valve,
Can we say increase heart rate?
it might increase the heart rate. Yeah.
Can we say that it it pushes more blood, so then it gets hard. And
Hypertrophy?
then it's like yeah, what Eric was saying,
Yeah, yeah.
hypertrophy.
Because the aortic valve, that's what keeps the left ventricle. It goes from left ventricle, aortic valve, and then into the aorta to go to the rest of the body, right? And so when that valve is stenosed, the left ventricle is trying to push that blood out to the body, and it can't do it as well. It's getting pushback from that valve. So that valve is trying to push harder and more forcefully. And remember, just like a weightlifter, when you keep going harder and more, you're going to actually build up more muscle, or heart will. And so it's going to build up and have hypertrophy, just like you said. All right, number 3. Why is angina a common symptom of aortic stenosis?
It's angina is a pain, right? Chest pain.
Yeah, chest pain, pain in the heart, from the heart.
I just know because things are not going right and that hurts, but
Is it because of the pressure in the heart?
Yeah, so
What about vasoconstriction?
not vasoconstriction, but if we think about the stenosis, right? And that ventricle, the left ventricle is really pushing hard to try to get blood out. It's actually not doing as good job as it should, right? It can't because of that stenosis. So there's not as much blood that's getting out into the system. At the same time, we have our coronary arteries that supply the heart. It affects them in the same way because we're not able to pump blood as effectively into those coronary arteries. So the heart itself isn't getting enough blood, just like the rest of our body isn't maybe getting enough blood. So when you're not getting enough blood, especially to the heart, that's when you start having some pain. And that's what causes the angina. All right, number 4, why is aortic stenosis treated with a valvular replacement?
open up the pathway.
Exactly. And then I think the answer here, I mean, I would say, why is it treated with a replacement? To me, that's what I was thinking, like, because we need to open it up. Here, they said that if it is significant, if the patient's having symptoms, those symptoms get worse. They can have sudden cardiac arrest. They can have heart failure. They can have an emboli, right? They can have a blood clot that forms in that left ventricle. The blood can't go like it should. And so if it's just kind of sitting there more, it's more at risk of causing a big or forming into a blood clot. So when it gets more severe, they do want to replace it because there are some pretty negative things that can happen. All right, so let's go to the clinical judgment part. When you're getting Miss Murphy's medical history, what does the nurse ask that's relevant to the cause of aortic stenosis? So we're doing our assessment on her, getting our medical history. What would be things that are significant to the aortic stenosis? I don't know if diet would be specific for this one.
High blood pressure, history of hypertension, or
I would say definitely a history, like cardiac history. Does she have a history of any other heart issues? What's that one heart issue they could have as a child that makes them more at risk for valvular problems?
Rheumatic fever.
Mm-hmm. Yeah. So when we're getting people's health history, if we're suspecting that they have a valve disorder, we want to see, do they have a history of rheumatic fever? Because that really lets us know this is probably the issue. What complications do we anticipate to monitor signs and symptoms that can occur in severe aortic stenosis? So aortic stenosis, the blood can't escape the ventricle. So what do we see? What happens from that?
Does it
Heart
back up?
failure.
Yeah, the blood backs up in the left ventricle. It might eventually back up to the rest of the heart. What does the body experience if it's not getting all the blood that it needs?
Fluid retention?
Sorry, one more time.
Like fluid retention or like build up around the heart?
Over time, it could, yeah. Initially, I think a lot of it might be things like fatigue, or they get short of breath with exertion because they're not getting blood, which is carrying that oxygen. And so they're like, wow, my body is not getting the blood it needs. I cannot do this. Over time, that left-sided ventricle that's getting kind of pooped out, that's going to lead to right-sided heart failure too. And that's where you would see more of fluid retention or edema and swelling. Don't worry about that now. We're going to talk more about that in heart failure next week. Miss Murphy's chest x-ray shows an enlarged heart. She asked why it's enlarged and how do we explain that to her? Anybody want to take a stab at it?
Because it's been working harder.
Yeah, your heart's been having to do more work. And because it's doing more work, just like that bodybuilder guy I like to talk about, it's building more muscle, it gets bigger. What about an S-bar handoff? Anybody want to say what the S might be?
she's experiencing some issues due to her stenosis.
Yeah, she's maybe here in the hospital. She has issues from her stenosis. She's supposed to have a surgery tomorrow to correct it. What about background with her? I probably want to include her vital signs, the last ones, maybe any health history, if she told us she did have rheumatic fever or anything like that. Actually, one thing that's probably pretty important with the background here, just saying she does have fatigue. I think it said that. And then when we move to the assessment, that's probably more where we put their vital signs. What's an important part about her story we'd want to include here in the assessment? You guys remember earlier in the story,
The history of the rheumatic fever.
that would be more like in the background. I'm thinking when she got up to walk in the hallway and started having angina, chest pain. Yeah, but that it was relieved with going to sit down. That's pretty important. That kind of tells us that, hey, her body is not handling activity, but if we rest, if we lower that activity level, then she's doing okay. Not good for long term, but that lets us know through the night, right? If she has to go down for an x-ray or something, we're not going to let her walk, right? We're going to be definitely taking her in a wheelchair, trying to decrease the amount of exertion she's having. And then recommendation, well, like I said, right, we want to keep monitoring that exertion level, keep her activity minimal, and probably start doing some education with her, right? She's going to have surgery tomorrow. So we're going to start doing some teaching about, hey, this is what to expect. This is what to do afterwards. All right. So this is now talking more about like the infection or inflammation of the vessels. So can you tell me of these words, which one is where your vein may feel like a cord?
Is it like a varicose vein?
Not like a varicose vein, but good guess. It's more so this one's kind of harder. This is probably the hardest one, the first one. Induration with superficial vein thrombophlebitis. So induration, we talked about that a little bit before with our PPD test for tuberculosis. The induration is that raised up piece on the skin. So when you have a vein that's irritated and inflamed, there's going to be some induration. So I think oftentimes like on my arm, let's say I had a vein that got really irritated. I was getting maybe some chemotherapy or vancomycin or something that was just really irritating to the vein. That vein, especially if I'm a thin person, is going to be kind of visible here. And you're going to be able to kind of feel that it's going to be raised up. It's going to feel a little bit harder. And this vein thrombophlebitis, that's where it's irritated. It's irritated on there, and it might have a little bit of clotting on there as well. All right, what about number 2? The sac surrounding the heart is inflamed.
It's pericarditis.
Pericarditis.
Yeah, good job from that word building earlier. You guys got it. All right, inflammation of the heart lining caused by microorganisms.
Infective
Infective
endocarditis.
endocarditis.
Yeah, exactly. Severe damage to the heart from rheumatic fever.
Rheumatic heart disease.
Yeah, that one's kind of, you're like, wait, is it that simple? Yes, it is. Solid, liquid, or gaseous masses of undissolved matter traveling within the current of blood or lymphatic vessel.
An emboli.
Yeah, I know that one, it feels so poetic. But you can have an emboli. A lot of times we think about a blood clot, but it could be air, right? That's why we're always so careful when we're working with IVs, because we don't want to inject air into the blood, because an air could be an emboli or something that kind of causes issue. It could be a solid
Fat,
matter,
right?
like with our bones, our long bones, if there's a fat emboli. Yeah, exactly. So it could be any one of those. Good job. You guys did so good on that. All right, let's find 6 errors and correct the information with rheumatic fever and rheumatic heart disease. All right, rheumatic fever occurs before a streptococcal infection, such as a sore throat. Rheumatic fever signs and symptoms include polyarthritis, subcutaneous nodules, chloria with rapid uncontrolled movements, or cholera. I have a hard time with that word. Carditis, fever, arthralgia, and pneumococcal disease. A throat culture diagnoses rheumatic fever. The heart valves and their structure can be scarred and damaged. Rheumatic fever can be prevented by detecting and treating streptococcal infections promptly with aspirin. All right, so we have 6 things that are wrong. Anybody want to take a stab at one of them?
The rheumatic fever doesn't occur before the strep.
Yeah, it occurs after. So change that to after. All right, 1 down, 5 to go.
Aspirin,
Yeah, what do we treat a streptococcal infection with?
penicillin,
Antibiotic.
Antibiotics,
yeah.
usually specifically penicillins. If they're allergic to penicillins, we might have to do something different. All right, 2 down, 4 to go.
The rheumatic fever, is it the uncontrolled movements?
Yeah, so this is cholera, and it should be chorea. Chorea is rapid, uncontrollable movements. Cholera is more like a old-timey disease.
But it's uncontrolled movements, right?
Oh. Oh, yes, you're
It's
right. They were
controlled.
both. You got, there's a 2 for 1 there. And uncontrolled. All right, I think there's just 2 left. Is that right?
Throat
Yeah, that
culture
one.
diagnosing rheumatic fever, doesn't it just diagnose the strep?
Yes, good job. Where is that at? Diagnosis. Now, actually, it does, it's usually a beta hemolytic strep. I'll put that in there. And let's see, and there's one more. I'll read the sentence. It's after the rapid uncontrolled movements, carditis, fever, arthralgia, and pneumococcal disease.
Is this pneumococcal disease? I'm curious.
Right, so it's more of if they get pneumonia, really it's pneumonitis. So they get like an irritation of their lungs, not necessarily full pneumonia. All right, nice job. You guys found you corrected all the incorrect responses. All right, so here, this is how we might test. So let's match the test with the finding that we might see. So the white blood cell count, what does that finding, like what does it tell us?
The causative organism?
Yeah. Actually, hold on.
Like it'll tell you if there's an infection.
It might not tell us the causative organism, but it will probably show an elevation, right? The white blood cell count isn't going to say specifically which organism is causing it, but it's going to say, hey, if it's elevated, that's letting us know there's some inflammation there, some infection.
I think blood culture show identify causative organism, right?
Yes, exactly. Good job, Hannah. Yeah, the blood cultures, that's what's going to be able, when we get our, they'd actually test specifically and see which organisms grow from there. Good job. Electrocardiogram, what will that show?
Arrhythmias.
Arrhythmias, yes. Chest X-ray.
Can I answer white blood cell maybe slightly elevation?
That's going to be, the slight elevation is the white blood cell count.
Uh-huh.
The chest X-ray, that's what's going to maybe possibly show us some heart failure. Like I said, like sometimes those hypertrophied chambers, it might show that it's larger than it should be.
Okay.
And then echocardiogram. That would be the vegetations on heart valves. So vegetations, it doesn't mean like broccoli or celery. It's meaning little growths. Sometimes when you have infections, you have those little infective organisms that go through the heart, and they can attach. Specifically, they like to attach on the heart valves, and they kind of grow there, and then you get these little bumps and these little nodules that grow on the valves, and you can see them on an echocardiogram, which is an ultrasound that you do of your heart. All right, prioritization. I love these ones. I feel like they're so good. A nurse is caring for a group of patients. After completing morning rounds, which one of the following patients require priority care? So this one, it's not asking us to put them in order of who's most sick to least sick. It's just saying you get report on these 4 patients. Which one do you go see first? That's what it's asking you. So I'm going to read through these. A patient with aortic stenosis who's reporting chest pain. A patient who's 2 days post-surgery reporting constipation. A patient with a deep vein thrombosis who has peripheral edema, or a patient with mitral valve prolapse who lost 1 pound of weight this morning.
Chest pain number 1.
Chest pain.
Yeah, chest pain. So anytime, especially if they have aortic stenosis, we know that the cardiac arteries, they're not getting enough blood to, to the heart. And so if they're saying there's chest pain, we need to look at that. It might require immediate action. The other guys, we're going to expect probably some constipation after surgery, and it's not an emergency. If somebody has a deep vein thrombosis or a blood clot, they're probably going to have some peripheral edema past where that blood clot is. That's, the thrombosis isn't expected, but we do expect to have some swelling associated with it. And a patient with mitral valve prolapse who lost 1 pound of weight this morning, I don't know, maybe he had a big poop. To me, that's not a very significant finding. All right, the next prioritization question. The nurse is collecting data on a patient who had surgery. Which of the following signs and symptoms indicate to the nurse the possible presence of a deep vein thrombosis in the patient's right leg that are a priority to report to the healthcare provider? Select all that apply. Oh goodness, let's break down this question really quick because that's a long one. So we're collecting data on a patient who had surgery. Okay, our patient already had surgery, so we know they're at risk of having a blood clot. Which signs and symptoms indicate possible deep vein thrombosis in the patient's right leg? All right, so the fact that it's telling me right leg, I feel like that's probably going to be significant. What do we report to the healthcare provider? All right, so let's just go through these one at a time, and let's just say, do we think that they're that they need to be reported, or do we not?
Right calf swelling.
So right calf swelling.
Yes, report.
Yeah, report, because if this, especially if we're looking at that right side and there's swelling, there's often swelling associated with a blood clot because the clot is occluding blood flow. So all that blood is going to back up and swell distally to where that blood clot's at. Bilateral crackles.
No.
No.
Yeah, those are usually a pulmonary issue. So it could be some heart failure, but that's not related to a blood clot necessarily. Jugular vein distension.
No.
Yes.
No.
No.
No, because again, that's usually
That's
more
a
with
little-
heart failure, not necessarily with a blood clot. What about a fever?
No.
No.
Actually, we can see fevers with blood clots. Our body has formed something that it's perceiving as an intruder. And so we can have fevers with blood clots.
Oh.
Right calf warmth.
Yes.
Yes.
Yeah, because if you have a blood clot, oftentimes there's some redness, warmth, and swelling that's there. Left calf tenderness.
Yes.
Redness? No.
No.
Yes.
Oh, redness. I'm sorry. Yeah.
Yes.
No.
No, because
No,
we're doing the right, not the left.
exactly. This was a trick.
Oh.
Right? It's a tricky question because if it was right calf redness, then yeah, we would want to report that. But the question is specifically saying the patient's right leg. So it's it's a trick answer here. So no, that's not correct. What about right calf tenderness?
Yes.
Yes.
Yeah, exactly. Those are the things we would report. Nice job. Okay, I just realized we're after 10 o'clock. How are you guys doing? Do you want to finish out this? I think we only have like the critical thinking after this. You guys good to finish?
Yeah, I think there was a question in the chat about if you were gonna like post all this in the slides and everything to our modules and like the answers to the study guide at some point.
Yeah, actually these study guides I posted in the announcement a few days ago, and the answers are at the end. And then the PowerPoints are already in the weekly module, what's it called? The resources. And then the new one, the new PowerPoint that I put up there, I'm going to be posting that in the resources as well.
Sweet, thank you.
Yeah, you're welcome. And you know what, guys, I'll include, sorry, I'm getting caught up on the chat. I'll include these, the study guides in the weekly resources as well. So they're easier to find than going back through and looking in the announcements. But if you want it before I get to it, it's in the announcements, the one I made a few days ago, and they all have the answers at the end here. All right, so going back up, let's do our critical thinking here. Miss Evans, age 68, is admitted to the hospital for heart failure resulting from hypertrophic cardiomyopathy. He has dyspnea, fatigue, and angina. His lung sounds reveal crackles. What is the pathophysiology of hypertrophic cardiomyopathy? So this is one of those things when I was saying there can be one disorder like cardiomyopathy that can be caused by different reasons. Mrs. Evans or Mr. Evans, his is hypertrophic cardiomyopathy. I think it'd be good, a really good study guide if you kind of create a column and have, or different columns and say, okay, cardiomyopathy for hypertrophic, what's the pathophysiology? What are some common causes? What are common symptoms? And then fill out the other causes of cardiomyopathy, or the other main types of cardiomyopathy, and kind of compare and contrast. I think that's going to help you understand them and kind of see where those similarities and differences are. So anybody want to take a stab at what is the pathophysiology or what's the dysfunction of hypertrophic cardiomyopathy? Let's word build a little bit. So cardiomyopathy, what is cardio?
Heart.
Heart. Myo, what's that usually stand for?
Cells, muscle.
Muscle, yeah, muscle.
Yeah.
And then opathy, what does that usually mean?
Like atrophy?
It's more like a dysfunction.
Like weakness?
Right, weakness, or it's not working correctly. So this is cardiomyopathy. It's when the heart muscle is not working like it should. There's a few different reasons. So this one is saying hypertrophic. What does hypertrophic mean?
That one is thicker.
Yeah, it's thicker. So if you have somebody like aortic regurgitation or excuse me, aortic stenosis, they're a very big risk of developing hypertrophic cardiomyopathy because they're building that bigger muscle, and eventually it might kind of poop out and get kind of tired, if that makes sense. So we just kind of talked about what the pathophysiology is. Really, it's that something happened with the heart muscle. It got really, or the heart muscle got really big, and eventually it kind of can start not working as well as it really should. Excuse me. In hypertrophic cardiomyopathy, what occurs to the ventricular size and ventricular filling with blood?
Getting small lines.
Yeah, that muscle kind of takes up some of the space where normally it would fill with blood. So what does that do to how much blood can get pumped out?
Not enough.
Yeah, not as much. It's going to decrease our cardiac output. What about what diagnostic tests might show hypertrophic cardiomyopathy and left-sided heart failure?
ECG, TC, something.
Echocardiogram? Yeah, or a chest X-ray
Didn't you say
too.
check? Yeah, check
Yeah.
X-ray because you said it would show up like a bigger
Right,
heart.
right. The heart's going to look a lot larger on the chest X-ray. Why would digoxin be contraindicated? So who can tell me let's go back and say, like, what is digoxin? What does digoxin do? Have you guys talked about this before?
Arrhythmic.
It relaxes the heart.
Mm-hmm.
Doesn't it constrict the vessels?
It doesn't so much constrict the vessels, but it's going to slow and strengthen the contraction of the heart. Now, do we want our heart to be contracting stronger with somebody who has hypertrophic cardiomyopathy?
No.
Not really. Their heart's already pumping really hard, really strong. That's why the muscle of the valve, or not valve, excuse me, the muscle of the ventricles are so big. We don't want to do something that's going to make it even bigger. So why should Mr. Evans be taught to avoid dehydration and exertion?
Exertion because his heart is already tired from pumping all this.
Right. Well, if we're talking about there's decreased cardiac output, there's not as much going on or not as much blood going out to the body, he's not going to be able to tolerate as much. Like our patient, Mrs. So-and-so, who's having surgery, right? She walked down the hall and started having chest pain because her heart was not able to pump enough blood to, accommodate that increased workload of just walking down the hall. With
I
Mr.
have a
Evans.
question, Rebecca, if you don't mind.
Oh, of course.
There is this digoxin.
Mm-hmm.
Did we guys say that it's for, what is it for? Like help you breathe better, right?
No. So digoxin is a medicine for the heart.
Mm-hmm.
Usually it's given for people who have a heart arrhythmia,
Mm-hmm.
sometimes for heart failure. What it does is it slows down the rate of contraction, and it also strengthens each contraction. It makes them stronger. We don't want to give it to Miss Evans because her ventricle is already enlarged. That muscle is really big in her left ventricle of the heart. If we have to strengthen it more, and if we're using digoxin to strengthen it more, that muscle is going to get even thicker. And as the muscle gets thicker, that space inside the ventricle actually gets a little bit smaller. So it can't have as much blood inside to pump out to the body.
Okay, I'm saying that because I saw in one of the passages they say you can give this digoxin to somebody who has a weak, like a weak heart. And then again, they say that you need to hold it when the pulse is below 50, 60, and then it was very
Right.
confusing, yeah.
Yeah, and so why would we hold this if it's less than 60?
Because it slows heart rate while
Yeah,
also increasing strength. But if it gets too low, then you're going to be screwed.
exactly. So even with somebody who we want to increase the strength of their contractions,
Yeah.
if their heart rate is already slow, we don't want to make it even more slow, right? Because we know that digoxin is going to lower the heart rate and increase the contraction, like the strength of contraction. So if one of those is going to do something bad for the patient, we're just going to hold it. We don't want to lower the heart rate lower than 60 because then they're not going to be pumping out enough blood to the body.
All right, thank you.
Yeah, you're welcome. It's a great question. So going back to Miss Evans, why should she avoid dehydration, or Mr. Evans?
Because there is no enough output, right?
Yeah, he already has low cardiac output. If we dehydrate the body, our cardiac output is going to decrease even more. And so they're going to have even more symptoms. Why is it important that Mr. Evans' family learn CPR?
In case, maybe he go.
Just in case. Yeah, and this was kind of a funny
They
question.
might need it.
Yeah, they might need it. So we know if he's got significant hypertrophy, he's at risk of having some sudden cardiac issues. So I don't know if I totally love this question from FA Davis. It's kind of their answer was the family will have a useful role and feel included in the patient's care. I think everybody should know CPR regardless. Is it more important that family knows CPR if somebody has a significant cardiac problem? Yes. However, if somebody needs CPR, they're already dead. If people like and this is totally just a tangent, this isn't anything I'll test you on, but the percentages of people that are successfully live after CPR, if it started in the field, meaning outside of a hospital, is very, very low. And so usually CPR is not effective. I don't say it's not effective, but you only do CPR on dead people, right? If somebody's heart has stopped beating, they're dead. You are doing CPR on somebody who's already passed. Now, occasionally you can help bring people back, but especially outside of a hospital, it's very rare. But like Davis says, it can give people purpose and make them feel like they have more control or more like a sense of purpose. I don't know.
Are we allowed to give the medication, what is that nitrate for this patient instead of CPR, something like that?
Good question. So they would only need CPR if their heart had stopped beating, right? Or if we needed to give rescue breathing, if they had stopped breathing as much, but their heart was still going. The thing about giving medications, if somebody has their heart stop beating, their medications, if you give them to them, they're not going to go anywhere in the body if your heart's not pumping them through. So occasionally, if you have a patient that's in a code situation in a hospital, they'll be doing CPR and they'll be administering medications in the IV. Typically, it's just emergency medicines, usually things like epinephrine, but you wouldn't usually give like a digoxin, and definitely wouldn't be something you would do instead of giving CPR. All right, any questions? Not so much. Okay, I'm going to be coming to Amanda's, not Amanda's. I'm going to be going to the, oh gosh, you guys, remediation class this week. And since we didn't get to the chapter 24, that study guide, we'll work on some of that during remediation. So even if you're not in remediation and you want to kind of work on some of this, you are welcome to come and join us and just get some practice in. One thing I'd love for you guys all to keep practicing, at the end of Davis, each chapter, like because I get some of the stuff is really dense. At the end of each chapter, they have these key points. And I'm sorry, I don't have it on my computer, but I have my book here. Oh Lord. Why is that? Why isn't it showing you guys? Weird. Okay. Oh, I have my background blurred. Hold on. I didn't want you to see my messy kitchen, but I guess now you get to see it. All right. So at the end of each chapter, they have these key points and they have all of these bullets through here. What I suggest is if you're reading through the book and you're like, okay, do I understand it? Do I not? Go back and read through these key points and see if those make sense to you, because they do a really good job of these key points of kind of summarizing everything. The other thing that I really want to encourage you guys to do is throughout the books, they have these, like here's a clinical judgment piece. So just kind of the clinical judgment, like what we were just talking through, they have similar ones or similar questions. They give the answers at the end of the chapter. And I think those also do a really good job of bringing the information together. And they also bring it together in a way that's similar to a lot of our test questions, where it's not just saying, do you know this information? Do you know what an echocardiogram is? Or do you know what is hypertrophy? It's then applying it. And so I think those are really good exercises for you to use. Excuse me. All right. Anybody have any last questions before we go?
I guess on the note of studying, because I emailed you and said I'm trying to make like a final exam study prep binders. So with your class, is it safe if I like focus on the PowerPoints, the FA Davis, the practice quizzes and FA Davis, and what you just talked about, kind of like the the study guides and like the studying, or do I need to also be cracking into like ATI and using their dynamic quizzing as well? I'm just trying to like, I don't want to
Yeah,
overuse so many
I understand.
resources.
I would say, I think ATI is a good resource. I don't recommend using it for my class unless you're having a really hard time with testing. That would be the thing. If you're a student who you have trouble understanding the test questions. I think a lot of times just practicing those NCLEX style test questions in general can be helpful. But FA Davis has those as well. Where you can make your own quizzes in FA Davis. So I would focus on just FA Davis. I would, the things that we've already, previous chapters, things about renal or endocrine. I would go back and maybe read over those key points, make sure those make sense to you. Look at some of the clinical judgment pieces, practice more quizzing. Yeah, I would focus. I don't think I would move to ATI unless you feel like you just need extra help with the testing.
Okay, thank you.
Yeah, you're welcome. Good question. Excuse me. Anybody else have questions?
Hey, Rebecca, we didn't have a chance to, to meet on the last day. Was it on Thursday or Wednesday? Because I came
Oh,
to the office, you were out of the office, and I still need the appointment.
yes. Yeah.
Yeah,
Send me
this is Kamami. That's my twin sister right there.
Oh, I was like, who is this person in class?
Yeah, it's me.
Send me a Canvas message,
Mhm,
and we'll get a time to meet on Tuesday,
mhm.
if that works for you.
Tuesday,
Not Tuesday.
we have class on Tuesday, right? Yeah. After the class, we can meet.
Yeah. What time is the
Yeah.
class over usually?
Is it 11 or some? Is it? I
Well, but
think we
then
have
we have
two.
remediation afterwards that she's joining. So
Remediation's not till 12:45 though.
Is Wednesday a good day? Because I'm off on Wednesday, so I can just drive to Courage. And
I'm not actually there this Wednesday. I'm
oh
there
yeah,
on
Tuesday.
I'm
Then
I'm there
that's okay.
Thursday, if that helps.
Sorry,
I'm there on Thursday.
the Thursday is so that we from 8 to almost 3. So Tuesday is a good day.
Tuesday. Okay. Yeah, let's just meet after class. So at 11 o'clock.
Yeah, that's fine.
Okay. Sounds
Okay,
good.
thanks.
Yeah, thank you. All
Mhm.
right. Well, I'll post this recording a little bit later once I get it uploaded. And like I said, I'll make sure that the study guides are in the weekly resource modules, but they're also in that, excuse me, in the announcement from a couple days ago. All the answers are at the end of each of these study guides. And then I'll see you hopefully on Tuesday at remediation. All right. Thank you guys for joining. Have a good rest of your weekend.